ready. Okay. So the only thing that we need to go over today is central nervous system and peripheral nervous system, correct? We went over everything else. Did we do spinal cord?
Yeah, we just had these two.
Okay. All right, so let's do, let's do central nervous system here first. Okay, so I only did a small little excerpt on ALS, okay, men greater than women. These patients are mentally intact. This is Lou Gehrig's disease. They end up paralyzed, but they're completely aware of their situation. And usually there's just death in 2 to 5 years. I know there was just a small excerpt about that, but the big thing we have to think about with ALS is, again, just like other neuro things, they've lost their protective reflexes, and we have to be thinking airway, right? We have to be thinking their ability to breathe. If they lose their muscle control, then we have to think about their ability to breathe. If we go to seizures, okay, we have focal or global. So remember, focal is just one part of the brain, and global is the neurotransmitters are firing abnormally throughout the entire brain. So it's something that's affecting more parts than just one small area. I think it's important to know the difference between pre-ictal, ictal, and post-ictal phase. So pre-ictal is like an aura or like a deja vu phenomenon. This is what happens before the seizure. And a lot of times patients that have had seizures before can tell you, oh my gosh, I know I'm going to have a seizure. I feel like I'm going to have a seizure. And this is why that vagus nerve stimulator is helpful in those patients, because they can feel that seizure coming on or that aura that they get before the seizure, and they can actually activate their nerve stimulator to prevent the seizure from happening. So that's the pre-ictal phase. Some patients don't have that, but a lot of patients do. Then your ictal phase is actually the seizure itself. So this is actually when your patients are having the seizure, and you should be thinking safety, right? We should always be thinking safety in the ictal phase. And then post-ictal is their recovery. So this is when your assessment is really, really important. How do you know your patient's having a seizure? Well, it depends on the type of seizure. And, we usually don't go, when you are with the patient and you start to witness seizure activity, these patients, nobody's going to come into the room and be like, do you think that this is a focal global, like a focal petit mal? No. They're going to ask you, what did you observe during the seizure? So, maybe they have a blank stare, or maybe they have rapid eye movement or eye twitching. Do they lose their muscle? Do they lose their muscle strength and they went completely atonic, right? They lost all of it and they literally collapsed to the floor. Do they have rigid movement? That rigid, quick, fast movement? Do they have anything clonic-tonic, rapid, big, exaggerated movements? Did they lose level of consciousness, any kind of lip smacking? Sometimes a seizure, the patients will actually just sit there and be in a blank stare, and they don't have a clonic-tonic movement, but they're unable to respond. They're like, they have that rapid eye movement and they're just off into a stare. So what is going on with your patient? Nursing role, our job when they're in the ictal phase is to observe the seizure, okay? And then of course, to stop the seizure. So observe it and to stop it. So we need to time it. And does the patient have a change in color, right? Because if they're actively seizing, and especially if it's clonic-tonic, are they breathing? No, they've lost all control of muscle strength. So these patients are usually apneic during the seizure. So the longer that they're in the clonic-tonic seizure, the longer that they're going to go without airway and gas exchange, right? They don't have a tidal volume, they're not pulling air in and out, and they don't have a gas exchange. So are they starting to turn blue? Do they have a change in color? How long is the seizure? Is there a mouth injury? Did they bite down on their tongue? Did they bite down on their lip? Are they salivating? What happened right before it started? Were you in the room, right? And then what else do we do? Our nursing role. So we observe it, we time it, we look for the patient, their actions. And then we have to keep them safe. Mark this down in your mind. Safety is the priority. Every other time you've ever been in a situation, we're always like airway. But I'm telling you, if you put your fingers into the airway of a patient as they are having a seizure, they're going to bite your fingers off, right? You are not going to try to pry open their jaw, injure them to put an airway in during the seizure. We've got to stop the seizure so that they can breathe on their own, or we can provide backup airway assistance. So our goal during the seizure is safety, safety, safety. We don't want them to hit their head. We don't want them to aspirate, we don't want them to have asphyxiation where they were like tangled in their clothing. So remove clothing, turn them on their side if you're able to. We can put on some oxygen So oxygen's never the wrong choice, like putting on oxygen. However, if the patient's clonic tonic all over the place and they're not breathing, like, is the oxygen really going to help? Maybe not during the seizure, but immediately after the seizure, if we have the oxygen on. But it's really hard to put oxygen on the patient. But the literature says to put oxygen on the patient. So make sure that if you're putting oxygen on maybe a mask, it's hard to get a nasal cannula in. They're not tangled, it's not tangled around their neck. Never leave them alone. So you're in the room, your patient starts to seize, or we have abnormal movement on a monitor and you're called into the patient's room, you see they're seizing, you're not going to go run and get help. You're going to hit the code button or you're going to hit the call light and get somebody in there right away. You stay with your patient. We should have suction at the bedside. We're looking for apnea during the seizure. Because if we have suction at the bedside, as soon as that seizure is over, is the patient vomiting? Are they salivating? Do we need to get into the mouth to prevent them from aspirating? And we need to stop the seizure, right? So great 5 minutes of continued seizure activity, or if they seize, do not fully recover and then seize again, then it's considered status epilepticus, right? And we have to stop that because we're going to have a gas exchange problem and these patients can end up with an anoxic brain injury, right? If we don't have gas exchange for 5 minutes, how much oxygen is getting to the brain, right? So we got to give drugs. So you're like, hey, my patient's seizing, I need anti-seizure meds, right? So many of you guys have given anti-seizure drugs on these units. We've been giving them at St. Joe's. I know that you're giving them in SIC, and I'm sure that you're giving them in Boardman. And we've been giving them a lot on PCC, not because the patient's actively seizing, but we're doing it to prevent the seizure, okay? So there's 2 drugs that you must give if your patient is seizing, 2 drug classes. So students always mess this up, but you have to give 2 drugs. One is to stop the movement. So you must stop the clonic-tonic muscle movement. And that's when you're going to give the Ativan or the Valium. Okay, Ativan is first line, Valium you can give if you don't have Ativan, but it stops that. It's the benzo that stops the clonic-tonic movement. Okay, I can't help my patient if they're flailing all over the place. The other drug that you must give is an anti-seizure drug to stop the abnormal firing in the brain. So you have to give this and you have to give this. If I just give this, Ativan, guess what's going to happen? These abnormal nerves are still going to fire in the brain. And it's going to, once the Ativan wears off, they're still going to be having this abnormal seizure activity. If you just give the seizure activity, they're going to still have this clonic-tonic movement because the anti-seizure drugs usually don't work right away. It takes minutes for them to kind of get kicked into the system. So you have to give both. So you may give Ativan and Keppra. You may give Valium and Dilantin. You may give Cerebrex and Ativan, but you have to give 1 drug from each class. So you must give 2 drugs, okay? Status epilepticus is greater than 5 minutes or no recovery between the next seizure. You guys remember Mrs. Phillips talking about sometimes it takes them 30 minutes to an hour to recover from a seizure before they're completely aware and they're alert oriented again. And we've got them back to a good place of vitals and breathing and level of consciousness. So if they have a seizure for 2 minutes and then they have a break for 10 minutes and they haven't fully recovered and they start seizing again, that is still status epilepticus because eventually we're going to end up anoxic, right? So the goal during the seizure is to keep your patient safe and stop the seizure, okay? And then in the post-ictal phase or the recovery phase, you're going to get your vital signs. You're going to check the heart monitor, right? Nobody's looking at the heart monitor during a seizure. What's it going to show? Rigidity, movement. Has anybody ever tried to put a blood pressure cuff on a patient that's having a seizure? Good luck. You can't do it, okay? We're not going to intubate them, but immediately after the seizure, if we see that the patient's been seizing for 4 to 5 minutes, are they anoxic? Yeah. They might gasp for breath or they might aspirate during the seizure. So we might need to provide intubation or mechanical ventilation immediately after the surgery if we can't get their oxygenation status up. So after the seizure in that post-ictal phase, we're checking our level of consciousness. We're checking vital signs, looking at the heart monitor. Do we need to intubate? Do we need to get gases? Get them on their side so that if they are vomiting afterwards or if they vomited during the seizure, we can try to get some of that out of the mouth so they don't gasp it down into their airway. Check the lactic acid, right? If you are seizing, we are causing a muscle, we're using muscle for energy, right? So we're in an anaerobic metabolism. So we are putting off muscle for energy. And we're going to cause muscle damage. So we can end up in an acidotic state. So we have to check that lactic acid level. We should be checking our electrolytes, right? Why did they seize? Do they have a traumatic brain injury and they have swelling in the brain? Or did they have some kind of surgery in the brain and they're more likely to have seizure activity or abnormal firing? Do they have an electrolyte imbalance? I always think sodium. So what's going on with that sodium level, right? Or do they have an infection, right? Look at your CBC, look at your platelets and your H&H, right? And then we got to so we talk about these anti-seizure drugs, but the big thing that we have to think about if we're giving seizure medication is check the liver function, right? So we've got to check our LFTs. We never stop. This is just like cardiology, right? We never stop our antiplatelet therapy unless we talk to the cardiologist, right? And I had 2 students on clinical. The patient had a heart cath. The patient was bleeding after the heart cath, but they were on aspirin and Plavix. And we said, nope, we're giving it, because they just had a stent put in and we didn't want to stop that drug. So we had to do things to control the bleeding, but we still gave our antiplatelet medication. It's the same thing in neuro, right? So you never stop your anti-seizure drug unless you talk to the neurologist. If your patient's NPO, because they're going to go for a procedure or a test, you don't hold the seizure drug or the anti-seizure drug, because what's going to happen in surgery? They're going to seize, right? Or the procedure, they're going to seize. So you find out if you can give the anti-seizure drug with a sip of water, or we get it switched to IV, but you never hold it without talking to the provider. Check your CBC, right? Because some of these medications can cause anemias, thrombocytopenias, leukopenias. They should take it the same time each day. So we want to make sure we're consistent. So if they take it twice a day, they should take it 9 at 9, 8 at 8. They don't want to skip doses. We have to teach them to make sure that they take it with breakfast and with dinner, or, however that looks like in their schedule. They're extended release medications because they work throughout the day. So most of them cannot be broken up. They cannot be chewed, right? So they have to be taken in a whole capsule. Okay. If we're giving IV meds, okay, so this is controlled medications that maybe we're giving oral. If we're giving IV meds, we have to watch IV. We have to watch for that extravasation, right? You remember the pictures of purple glove? That some like Dilantin can literally slough off the skin. I've seen it before. I've seen it in patients. So they can have that. If we have extravasation, it can actually cause the patients to cause cellular death of that subcutaneous tissue. We must give it slow. Okay, if we give it too fast, you can cause the patients to go asystole or bradycardia. We should watch our vital signs during administration. Many of them can't be mixed with dextrose, only normal saline. Okay, no Dilantin. I'm telling you, when I teach this, I ask a question about Dilantin every single time. Know the side effects of Dilantin. Know your Dilantin levels. I'm telling you, you need to know that Dilantin. And if Mrs. Phillips is writing a question, Dilantin is such a highly asked question on board, and it's something we give a lot in practice. You need to know the drug. Other things that we can do is, can we send the patients to surgery or the vagus nerve stimulator? These things help. So the vagus nerve stimulator, it actually can help during seizure activity, or it's kind of preventative. So every so many seconds or so many minutes, it stimulates that vagus nerve to try to prevent the seizure. And then, some of the patients have the magnet, so they can wear the belt, or they have a magnet where they might wear a watch with a magnet, and anytime they have that aura in the pre-ictal phase, they'll actually swipe it. It stimulates the vagus nerve to prevent the seizure activity. Okay. Any questions? That's the down and dirty on seizures. That's the take home. Safety, 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 stop the seizure, assess, assess, assess. Okay. And then know the drugs. Okay. Know Dilantin, know that you have to watch for your liver function. You have to watch for your penias with your CBC, not to stop the medication without talking to the provider. You don't want to give it with dextrose, only normal saline. Good. Silence means keep going. So I'm going to keep going unless you guys stop me. Okay. So then migraines. So here's the interesting thing, a lot, because we talk about the nerves and how the nerves function, and sometimes blood flow to the brain or to the nerves. Migraines, we use a lot of the same medication. So study the medication once and know that it's used for 2 different reasons, sometimes 3 different reasons. So just like seizures, you have, your seizure, you have a pre-ictal phase, and then you have an ictal phase, and then a post-ictal phase. It's the same thing with migraine. It's pre-headache, which you might get an aura. Those of you that get migraines know a lot of times you get this aura, like you might have blurred vision or see black flashing dots, or you might have a feeling of like a hunger, or a thirst. I used to get migraines and I'd always request caffeine or Pepsi. And then I was like, oh my gosh, as soon as I drink this Pepsi, I know I'm going to end up with a migraine. And then you have this headache, which is actually just like the seizure, it'd be like the ictal phase, the headache phase, which is where they have the terrible pain. And then the post headache phase, which is the recovery phase. And they have a lot of fatigue and exhaustion. So migraine, again, there's no like migraine test, you know, it's a clinical diagnosis. And we have to rule out other causes. So when people start coming in with a lot of headaches, a lot of times we'll do a CAT scan or MRI of the brain to make sure there's not some kind of tumor or something else being caused. First line, we use a lot of NSAIDs. So like ibuprofen, Aleve, Motrin, and prescription strength. And then second line, we go to abortive drugs, right? So now we go to something that would stop the migraine when it comes on. So these are your triptans and your ergos, right? So triptans would be like Imitrex, you know, that's been on the market for a long time, or Relpax or something like that. So those are your triptans and your ergos. So what happens, and I think in the migraine is there's like this intense pressure from the blood rushing to the head. So it's like boom. And a lot of patients will feel like their head is throbbing. Well, every time your heart beats, it's like the blood's like boom, boom. It's like boom, 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 up into the brain. So if we give a triptan or an ergo, it's actually like a vasoconstrictor, right? So if we give that vasoconstrictor, we're decreasing the blood flow to the brain, and it usually works really, really well. But if we have vasoconstriction, we have to be really careful about what patients we give those to. We would never want to give those medications to cardiovascular patients that have coronary artery disease or ischemic heart disease. They already have clogged vessels. We don't want to give something that's going to clamp down the vessels because we're going to cause them to have a heart attack or a stroke. So if they have cerebral vascular disease or coronary artery disease, or we have to be super careful. Pregnancy, we don't want to cause vasoconstriction. We don't want to decrease blood flow to the baby. And then we, you know, so I have that, I'm ahead of myself. So I have that information here. And then we want to avoid giving 24 hours apart. So you wouldn't take a triptan and then a day later, or like 20 hours later, take an ergo on top of it, because they essentially do the same thing and they'll cause potent vasoconstrictive and cause major problems to patients. If we use NSAIDs and that doesn't work, and then we move to abortive drugs, and now the patients have 6 or more migraines a month, or 5, or they have 2 or more debilitating migraines a month, or they start to, now they don't have enough, they can't take abortive therapy because they're getting migraines too frequently, then we go to preventative therapy. Okay, so we can prevent with our anti-seizure drugs. We can prevent with NSAIDs, beta blockers, and remember, these beta blockers aren't cardiac selective. So you might see like Inderal or propranolol, just like we did with the liver. We might do beta blockers to control that pressure. We might do calcium channel blockers if the beta blockers don't work. And then sometimes we can use antidepressants. Really, so you can take these preventative medications and then use abortive therapy on top of it. So like you do preventative, so maybe you get 10 migraines a month, and now you're on preventative therapy. So now you're down to 4 migraines a month. And when you get those 4 migraines a month, you take your abortive therapy to control the migraine. A lot of patients you'll see with migraines try to save their abortive therapy because they know they only get so many a month, and they're like, I don't want to use them. But that's really debilitating. So really it's important for us to teach the patients to make sure that as soon as they start to feel that migraine come on, they should take their abortive therapy immediately, not wait, because there's nothing else that's going to get rid of the migraine. It's important to have them journal. So like, let's look at triggers. So we want to make sure we teach them to avoid foods with tyramine in it. So anything processed, like all the good stuff for a Friday night, right? Like cheese, wine, processed meats like salami or prosciutto or pepperoni, those kind of things have a lot of tyramine in it, so are triggers. And then caffeine, sometimes caffeine withdrawal can cause a migraine, or too much caffeine can cause a migraine. So it's really important for the patients to journal, look at their lifestyle. Sometimes just not drinking enough water, dehydration, those kind of things can actually trigger a migraine, but that really helps the patients. Okay, questions on migraines? Okay, so let's move on to Huntington's. Huntington's is genetic. We'll see a little bit more. Sometimes they say male equivalent to female. I've heard a little bit more, sometimes male more than female. But these patients lose their muscle strength and they have this choreiform movement. Oh my gosh. So for the spirit of spring break and for us just trying to have fun today, I'm going to try to record myself doing cuneiform movement. Okay. So when you think of Parkinson's, and we're going to talk about that here shortly, Parkinson's, remember the patients, let me move my chair and see if I can record this pretty well for you. Dr. Colmer says I do a pretty good, so Parkinson's, and I usually mimic this in the classroom, is, you know, they're hunched over. Okay, take this off too. They're hunched over, and in Parkinson's, they're head forward, they're hunched over, and they have this cuneiform movement, shuffle gait, right? And their mask-like face expression, super slow. They don't pick up their feet, and they have this tremity, rigidity. Okay. In cuneiform movement, that is the hallmark, is they end up with this cuneiform movement and dementia. Okay. And they can end up with a little bit of dementia with Parkinson's too, but Huntington's, so this cuneiform movement is rapid cuneiform movement. So it's very like, so when they move their arms, they're very exaggerated. If you Google anybody that has like, and so it's very exaggerated, arm comes up, comes back down, leg comes up, comes back down, versus Parkinson's, which is very slow, rigidity, pill rolling, slow, like tiny, tiny movements. So the hallmark to Huntington's, and this is a genetic dominant trait, is that cuneiform movement and dementia. They lose their muscle strength. They can have trouble respiratory. They can lose bowel and bladder function, but they end up having some personality changes. Usually we see death in like 15 to 20 years with Huntington's. So they'll have some bowel, bladder, and personality changes where sometimes they start to become very aggressive and impulsive, and they're hard to control because they start to have this dementia, so they're confused, and they have this rapid movement, so they're high risk for injury, and then they're impulsive, right? So very, very hard to deal with the further they get into the disease. Any questions about Huntington's? No cure. Most of these, like migraines, no cure. Seizures, usually no cure. Don't forget too, with seizures, I just looked at this, I forgot. No driving 6 months after a seizure. So patients sometimes, after they are under control with their seizure activity, then they can drive as long as they're taking their medications. Sometimes patients with status epilepticus that, you know, we have a hard time controlling the seizures aren't able to drive. So that they have to be cleared by their neurologist to drive. So we usually say about 6 months after seizure activity. Okay, any questions on Huntington's? Okay. All right, let's go to Parkinson's. Okay, so these are like the nerve disorders that are terrible, because Parkinson's, again, no cure. It's chronic and progressive, and we're like, this is what I was talking to you guys about initially before we started recording. I probably should have recorded that part, but we're lacking the dopamine and we have too much acetylcholine. Okay, these patients mask-like face expression, they're stooped posture, they have a pill roll tremor, muscle rigidity, they have trouble swallowing and blinking. They have an arm swing sometimes. You'll see them with a swinging arm because they don't control the muscle very well. So when they're walking, it just kind of swings. They have a resistance to passive movement, shuffling gait, and constipation. Big deal with constipation, right? And then their tremors worsen with stress. So when they're trying to go and do something, the tremor kind of worsens with stress. How do we know that they have Parkinson's? Well, we have to have 2 out of the 4 cardinal signs. So they have tremor, rigidity, bradykinesia or akinesia. So they have loss of movement, and then postural changes. And how do we confirm this diagnosis? Well, we start them on Parkinson meds like levodopa, carbidopa, or Sinemed, and we see that they respond well to that. So we have to, then we know that we're treating the right thing. So treatments are a dopamine agonist or anticholinergic. So we start with the dopamine agonist. So that remember, agonist promotes an action. So we're giving dopamine back to promote that dopamine synapses. And then we have then we can give our anticholinergic to block that cholinergic synapses where it keeps firing, that causes the rigidity. Okay. Big thing you have to worry about with these like anti-Parkinson's drugs is you have to worry about orthostatic hypotension. That's like the big deal. So let's see, carbidopa, levodopa, big deal, first line drug, avoid extra proteins, change position slowly, and we have to think about orthostasis. Jake, I know that you're on here, but this is exactly what I was thinking about. That patient we took care of on PCC, right? She was extremely hypertensive when she laid down, but because of her Sinemet, her Parkinson medication, when she would stand up, her blood pressure would drop significantly. They can have a dark urine, they can have dyskinesia, so difficulty with muscle movement, and they have this on and off phenomenon. And this is when we have to supplement other medications. Well, when the Sinemet's working, great, it's working really, really well, but when it's not working, they had this on off. So it's like, we talk about the temperature changes and how it becomes really drastic in neuro patients, and we don't want that. Same thing happens with this medication. It's not temperature related, but it'll work really well, then not at all, then work really well, then not at all, right? So we want to supplement something to give either another dopamine medication to make sure when it's working, it stays working, or we can supplement with an anticholinergic to prevent that rigidity and muscle tremor. Big things we have to think about with Parkinson's, though, is we must help with ADLs. Okay, these patients lose their ability to care for themselves. Communication is a big deal. So making sure we give them time to communicate. We're slow with communication. Nutrition, we have to think about protein, but think about foods. So they have trouble swallowing. So we have to give soft foods, give them time to eat, worry about aspiration and choking, right? Mobility is a big deal. High risk for falls. They have that shuffling gait. So you have to really think about making sure that they don't have rugs in their apartment or cords or any of those things. And then bowel elimination, they're constipated, right? So we have to make sure that we're promoting good bowel movements, trying to increase the fiber in their diet. And then do we need to give stool softeners or laxatives to help them with that? And then just remember that this is not reversible. It's progressive and irreversible. So we can't reverse Parkinson's. So you're not going to give a drug to make them better or reverse it. You can't go backwards. You're going to try to stop their symptoms where they're at and prevent it from progressing further. Okay. Questions on Parkinson's. Now that we talked about that acetylcholine and dopamine, does that help you understand that a little bit better, why we give those treatments?
Yes, thank you.
Okay. All right. So then let's go back to Alzheimer's. Here we go. This is sad, right? Chronic, progressive, irreversible. These patients lose memory and judgment. They have a personality change and usually dementia in the elderly. And sometimes they can even start with the delirium. There's no test for Alzheimer's, and usually they diagnose it on autopsy. It's a clinical assessment and we rule out other problems first. So if we rule out confusion, or if the patient's confused, what are we ruling out? Well, we're looking for stroke. We're looking for something else that, like maybe a medication, a side effect, or something else that can be contributing to their confusion. And then we say, okay, we've looked at CAT scans, we've looked at MRIs, we've looked at the drugs. And then we start to say, okay, now that we've ruled out other things, we can call this an Alzheimer's. So let's look at these by stages. So stage 1, they easily forget their names. They have a short attention span. They forget household items. Like they might use a brush to cut a piece of meat or something like that. So they forget what the item is used for. Small personality changes or behavior changes. Sometimes they wander and they have problems with judgment. So a lot of times in stage 1, patients know, they're aware enough to know that they're confused. They know it and they don't know why. They get frustrated and can be irritated sometimes. So like, here's an example, like maybe you would say, what month is it? You're doing a level of consciousness and you're trying to sense their level of awareness. And so they tell you their name and then they tell you that they're at the hospital and you say, what month is it? And they're like, now you know what month it is. What are you asking me that for? So they know they can't remember the month, but they're witty enough and smart enough to give you an answer to, no, come on, you know the month. Or if I say, well, where do you live? Well, you know where I live. It's right in my chart, even though they know they can't remember their address or their street or where they're at. Okay. So in stage 1, you'll see a lot of that and they can become irritated and you don't want to fight with them. You don't want to support the delusion. So if they're like confused about something and they're like, yeah, no, we're in Alaska. You don't want to be like, yeah, you're in Alaska, because we're not in Alaska, right? Even if there's snow outside or it's cold outside, but you want to make sure that that you don't feed the delusion, but you don't argue with them, because that makes them get upset and it get worse. So if that's the case and they're arguing with you about something, then you want to just change the subject. Don't feed the delusion, but you don't want to argue with them. So change the subject. And so like, we're in Alaska, and be like, okay, what are we going to do for breakfast today? What would you like for breakfast? And just change the subject. Stage 2, they have a severe impairment of all cognitive function. So they wander, they're incontinent, they're very agitated and depressed. They have speech and language deficits. So at this point in stage 2, they really should not be left alone. Even in stage 1, there's a lot of times that they shouldn't be left alone, but stage 2, they shouldn't be left alone because they're high risk for injury and falls and escaping. These are the poor patients. Oh my gosh, I get sick to my stomach when they were like, somebody gets brought into the emergency room. We found an elderly patient who escaped from the nursing home. We found them, down in the snow or something, and they've been missing for 12 hours, so they wander and escape, and it doesn't have to be from a nursing home, it could be from a home or wherever. And then stage 3, they're total dependent ADL. So they can't do anything for themselves. They lose all verbal skills, motor skills, and have major neurodeficits. So these patients require total care, even hospice sometimes. So how do we help these patients? Well, again, it's progressive, it's not reversible. So treatment early, we want to do things that are repetitious in their day. So we want to provide them with clocks so they can easily see the time, calendars so they know what month it is, pictures, and reorient them to the time and to the place, but don't reinforce their delusion or don't argue. So it's really good for them to have familiar faces of pictures of people that they know. When they're late into Alzheimer's, acknowledge their feelings, but don't reinforce or argue. If they're in mild to moderate Alzheimer's, we do Aricept. You guys probably see that advertised on TV. We give it all the time in patients. If we're going to give Aricept, it's really important to check for bradycardia, syncope, and incontinence. If they have moderate to severe Alzheimer's, we usually go to something like Namenda, if you guys have heard of that drug. Important to check for dizziness, severe renal impairment. Big things we need to focus on is communication, ADLs, nutrition, and family support, because these patients require a lot of family support. Other things I think about is like making sure that they have a lock on the door, that the patient can't undo the lock so they can't escape and wander, so it'd be really important to make sure that the doors are locked and they can't reach the lock or they don't know how to maneuver the lock. They shouldn't be left alone where they would turn on the gas stove, or, you have to check the water temperature because you don't want them to burn themselves because they don't know how to turn on the faucet or something like that. So just think, and I think this is a really sad way to think about it, but I think of it as like how you would baby proof your house for a toddler would be the same way. Like you wouldn't let your toddler turn on the water by themselves. You wouldn't let them get to the door and unlock it because they would wander and go somewhere where they weren't allowed. You wouldn't leave the door open to the stairs because they would fall down it. So all those things, and it's sad to think of it that way, but that's the same way you should approach these patients, is how do you keep them safe? Because they're unaware of how they can harm themselves. They lose that self-awareness. Okay. Questions on Alzheimer's? All right, that's it for CNS. Anything else we want to talk about for CNS, or any questions? Okay. Well, let's move on to PNS then. Okay. So if we talk about the peripheral nervous system, okay, the two big things you can see here that take up most of the concept map are your Guillain-Barré and myasthenia gravis. Okay, so we'll start with Guillain-Barré. Usually 1 to 4 weeks is initial onset, and then after that, days to weeks will plateau, and then recovery is up to 2 years. You can imagine the rehab time for these patients. Both of these, myasthenia gravis and Guillain-Barré, students get them confused. So I'm going to go back and forth to try to point out the differences to help you remember them. But Guillain-Barré and myasthenia gravis, they're both autoimmune. Okay, so when we talk about the Guillain-Barré, it's the myelin sheath damage. So if you guys think about the nerve with the axon and the tail, okay, we talk about an axon injury where they're torn off of the nerve. When we talked about like that shearing force from a traumatic brain injury. Well, along that axon, there's these myelin sheaths. And in Guillain-Barré, in every patient, the nerve impulse is sent down the sheath to be connected to the muscle. However, in Guillain-Barré, the immune system attacks the myelin sheath. So it's like the telephone, like pass the message all the way down. You know, if you play telephone, tell this person, tell this person, tell this person. Well, if you move somebody out of the chain, then the message can't be passed along. So the same thing happens. The immune system attacks those myelin sheaths, and then the message can no longer be passed along. So the damage is to the myelin sheath of the nerve. Myasthenia gravis, it's the acetylcholine receptor, okay? And it's attacked. So if the acetylcholine receptor that connects and pushes along that nerve synapses is attacked, then we don't have acetylcholine to connect the message to the muscle, okay? So then we have to fix that. So that's why the treatments are sometimes similar, but a little bit different. So they're both autoimmune. So what do we have to do? We have to focus on fixing the immune system, right? So Guillain-Barré is usually brought on by some kind of illness, usually preceded by an illness by 2 to 4 weeks. So maybe they got a vaccine. If you guys ever looks at those vaccine information systems, for almost every vaccine out there, it'll say if you've had Guillain-Barré before, you shouldn't get a vaccine. You should look for neurological symptoms 2 to 4 weeks after giving this vaccine. Maybe they had acute illness, viral. Did they recently travel somewhere? Did they recently travel somewhere where they were doing, you know, eating food or something and get like a viral illness from another country? Did they have some kind of GI symptom or some kind of GI infection? Usually we'll see this in the younger age group, so like 15 to 36, and then middle age 50 to 75. There's multiple types of Guillain-Barré, but the type I want you guys to focus on, which is most common, is ascending paralysis. So this means it ascends up. It starts in the feet and it works all the way up, okay? Usually there's a fast onset, and then when they heal and they improve, they heal in reverse. So then we'll start to see the muscle strength and movement come back and work its way down. And the last thing that they'll regain muscle movement in is the feet. Signs and symptoms, they can have paralysis, they can have pain or numbness, they can have weakness, they can have cough, facial problems, speaking, diplopia, okay? They can have tachycardia, dysrhythmias, and then a low blood pressure. Okay, how do we diagnose Guillain-Barré? Well, sometimes we can do a lumbar puncture and we'll see an elevated protein, elevated WBC in the blood, and elevated liver function test. But the big thing we look for is a history of viral illness a few weeks before. So did they travel outside of the country? Did they have a GI illness, a respiratory illness, something like that? What do we worry about if these patients have Guillain-Barré? Well, we worry about breathing. So once, I always tell patients, once the muscle strength and loss hits the elbows, we should be thinking respiratory. Because think about where your elbows hit. If you held your elbows up against your waist, you're now hitting the diaphragm. So now you're at a point, and if it comes on fast, if we're at the diaphragm, that diaphragm might be paralyzed and may not work to help the patients pull in their tidal volume. So we should be thinking about that. These patients will have a decreased tidal volume, right? So tidal volume is the amount of air that you're able to breathe in and out with every breath. So they're not going to be able to. If that diaphragm's paralyzed, they're not going to be able to open and expand those lungs, or decrease vital capacity, which is breathe in, out, and what's left over. Okay, so you're going to have a decreased tidal volume, decreased vital capacity. They end up in respiratory acidosis because we don't have good gas exchange. We're not able to blow off our CO2. Treatment is respiratory priority. Okay, so do we have to intubate them and provide mechanical ventilation? There's nothing that we can do to make the muscles work until the Guillain-Barré subsides. So sometimes these patients might have to be intubated for days, weeks, depending on where they plateau at. Other treatments that we can offer these patients is plasmapheresis. So remember, this is autoimmune, right? Guillain-Barré and myasthenia gravis, autoimmune. So what happens is we develop antibodies that attack the myelin sheaths of the nerve in Guillain-Barré. So what do we need to do? Well, let's remove those circulating antibodies. So plasmapheresis is very much like dialysis. They pull the blood out, they remove the circulating antibodies, and they put the blood back in, okay? We weigh the patient before and after plasmapheresis. The blood's removed, plasma's removed, the cells are returned. If we remove the plasma, and very often we don't give the plasma back because the antibodies are in the plasma, then we have to give albumin to replace the plasma and to increase that intravascular volume. So we give albumin in the body to replace the plasma, or sometimes if we don't remove a lot of plasma, we allow the body to replace its own plasma. They usually get this treatment 3 to 4 treatments over 1 to 2 days. These patients, so here's the big things. You know, we think autoimmune, so steroids, we love those for the immune system, but steroids don't work in Guillain-Barré. Very interestingly, they do not work in Guillain-Barré. So these patients do not get steroids, even though it's autoimmune. Okay. We can give IVIG, really good. IVIG, we give immunoglobulin to help the immune system. It's an immune disorder. We infuse this slowly. We have to watch for anaphylaxis because of the immune system. They can have retinal necrosis and acute renal failure. Okay. Worry about if we're giving plasmapheresis. This is really important. Highlight this. Okay. If we're giving plasmapheresis, we have to watch hypocalcemia, hypovolemia, and hypokalemia, because we're pulling the plasma out, or we might be pulling out calcium, we might be pulling out potassium, and we're pulling out volume. So hypovolemia, we have to watch for the low blood pressure and tachycardia, hypocalcemia. So think of all the hypos: hypovolemia, hypocalcemia, hypokalemia. Watch for hypotension, and then they're going to be tachycardic because it's going to be compensatory. And then down here, I have other stuff. Well, I didn't put it on here, but if your patient is not able to move, right? They're paralyzed because of this Guillain-Barré. We have to think about muscle contractures. We have to think about DVTs. We have to think about skin and immobility. So range of motion, right? All that other stuff that you should be thinking about in any ICU patient that's intubated, we should be applying here too. So are we doing DVT prophylaxis? Do we have TED hose and SCVs on? Are we worried about, foot drop? So do we have like the Prafo boots on them? Are we doing range of motion? Are we turning them? And then all the other things, if they're intubated, think about what you have to do for your intubated patients. Are we suctioning? We're making sure that we don't have ventilator associated pneumonia and all the stuff that goes along with ventilators. Okay. Questions about Guillain-Barré? Most of these patients fully recover. It just takes a long time. And they have to think about like depression and things like that because they're not up getting around, and think of like the muscle loss, the muscle mass loss, and all of that kind of stuff.
So how long is the onset of this? Like how long? Because I know it's like a gradual progression.
Yeah, usually the onset is usually usually what will happen is you'll see the onset will be it's slow, but then it can be fast. So it could be anywhere from like 1 to 4 weeks will be the onset, and then they'll plateau, which lets us kind of know where the muscle impairment is gone. It doesn't continually gradually go. It'll plateau usually within 4 weeks, sometimes up to a week or two, but usually 2 to 4 weeks, they'll plateau, and that's where we know where they're at. And then after they plateau, we'll start to see that slow decline where they'll start to improve. So it's like a quick plateau and then a slow healing process.
Okay, thanks.
Mm-hmm. Okay. Any other questions? Otherwise, I'll go on to myasthenia gravis. Okay. So myasthenia gravis, again, autoimmune. Okay. And as we talked about earlier this morning, we have acetylcholine receptor is attacked. So we don't have that cholinergic synapses to help the nerve transmit the motion to the muscle. So if the nerve cannot communicate with the muscle because the transmitter is not working or it's being attacked, then the muscle doesn't move. Because it's so Guillain-Barré, ascending paralysis, I always think of myasthenia gravis, small muscle to large muscle, small to large. And hallmark, you'll see diplopia and ptosis. So ptosis is the eye drooping. So you'll see eye drooping on one side or both. And then diplopia is double vision. So I always think eye first, okay? Don't forget that there could be a thymus involvement, or they could have hyperthyroidism, and usually women greater than men, and usually onset is in 20 to 30 years. There's no cure for myasthenia gravis, but it's lifelong, and they can have periods of exacerbation and remission. And this kind of goes a little bit more along with autoimmune disorders. If you think of like rheumatoid arthritis, periods of exacerbation and lupus, exacerbation and remission, where the patients are doing really well, and then usually infectious or stress or illness activates that immune system, and then that causes an exacerbation. The same thing happens with myasthenia gravis, okay? So happens small muscle to large, okay? It can be slow or fast onset. So sometimes the onset's slow, and then if they have an exacerbation, the onset is fast. The exacerbation can happen fast. This is lifelong, and then there's, like I said, peaks or valleys. I'm just getting ahead of myself there. So signs and symptoms, the two most common, I have them first, ptosis and diplopia. They can have muscle weakness, and then we have to worry about, like, as it moves to the large muscle, like I think facial. So they might have like blurred vision, eye drooping, and facial drooping. They might have trouble moving their tongue and swallowing, talking, holding the jaw open. So a lot of times their jaw will sit open. And then it moves to large muscle. The interesting thing, you know, that we have to think of, these patients typically don't end up with muscle atrophy. Okay. So the muscles don't weaken because guess what? They're not constantly paralyzed. So in the middle of an exacerbation, the muscle is weakened, but they don't atrophy. You don't see the arms or the legs atrophy because they're not constantly being impaired. We're like Guillain-Barré. If they're not moving that muscle for almost up to 2 years, of course it's going to atrophy, right? You're going to lose muscle mass because it's not moving at all. Myasthenia gravis, once we get them into remission, which may take, I don't know, a couple days to a couple weeks, then you'll see that muscle strength be fine. So that's kind of the difference there. So how do we diagnose them? Then we can check for this acetylcholine receptor antibody. We're looking for the antibody that's attacking that acetylcholine receptor. We can do the tensilin test. I have this marked in red because it's important. When we give the tensilin, the patient has rapid improvement when the medication's given. However, it can cause the patient to be bradycardic almost instantly. So when we do the tensilin test, we must have atropine at the bedside. Because they can have bradycardia, abdominal cramping, and they can sweat. So treatment, chronic treatment, we kind of keep them into remission, okay? And then if they have an acute exacerbation, we give steroids. So here's the difference. Steroids did not work in Guillain-Barré, right? Even though it's autoimmune, steroids do not work. Myasthenia gravis, they love steroids. It works wonderful, just like every other autoimmune disorder. What do? We give steroids to put them into remission because it works really, really well. So we give steroids and we suppress the immune system. So just like Guillain-Barré, we could do plasmapheresis. Remember, we have antibodies circulating, so we do plasmapheresis, remove the circulating antibodies. We can do a thymectomy. Remember, if this is related to the thymus gland, we do a thymectomy. And then if we do a thymectomy, we have to look, why is the thymus involved? Is it because it's abnormally enlarged? Is it not working? Does it have a tumor? Is there cancer? And then a lot of times to put them into remission, we give mestinon, which is, or progesterone or progestamine. It is a cholinergic medication, right? So remember, we have an anticholinergic or we have a cholinergase where it's being attacked. So let's give cholinergic to the patient to allow that muscle synapses to work. It's really, these patients take this 5 times a day. It's first line therapy. It doesn't necessarily work when they're having an exacerbation. This is a medication that kind of supports remission and it helps their symptoms. So it doesn't fix the immune system, right? The immune system is the problem. So when we give the steroids or we give IVIG or we give plasmapheresis, we're working on the immune system and those circulating antibodies. When we give mestinon, we're working on that nerve synapses and we're trying to just make the nerve and muscle function better to try to promote muscle function. So we're giving mestinon continuously to help these patients hold their eye open and to prevent the double vision and to allow them to chew and swallow better. So if they have a lot of eye drooping, these patients can end up with corneal abrasions or trouble because what happens think of your ICU patients and how many times we give them eye drops if they're on paralytics. These patients, every time they blink, it lubricates the eye. Well, if their eye is like this and we're not blinking, then they can end up with a dry eye or if the eye is like partially drooped like this, they can end up with the eye being dry. So we might have to lubricate the eye. We might have to put an eye patch on to allow the eye to rest. And it's really important with these patients with this mestinon that we give it on time. They take this medication 5 times a day. And it's really, really, really important to give on time and then to eat 1 hour afterwards, right? Because we don't want them to choke and aspirate. So these patients have to balance activity and rest. Really important to balance activity and rest. So they wake up and mestinon can be irritating to the GI tract, right? So they should maybe keep it by their bedside with a little glass of water. They rested all night, right? So they should be able to take the mestinon with a little bit of applesauce or a cracker, some water in the morning, get up, maybe brush their teeth, go to the bathroom, allow the medication to work, now eat breakfast, okay? And then they would do some activity, rest, take their next dose, and then have lunch, okay? So these patients do not do well with a lot of activity planned back to back because they get very fatigued and then the myasthenia, their muscles start to fatigue and they don't work well, okay? My grandma had myasthenia gravis, and we would schedule her doctor's appointments at like 9 or 10 in the morning. We would get her up, give her her Mestinon, give her something to eat, take her to the doctor's, but then we wouldn't go to lunch afterwards because it would be too much for her. So we'd come back home, let her rest. She'd get up, maybe we'd go to lunch, or she'd eat lunch. Okay. And I'll tell you a funny story. My grandma used to love to play cards, right? So I always think about this with the eye drooping. And so she loved to play cards. We'd go over and play cards, or she liked to go out to eat. So my cousin and I, when we were taking care of her, we would use the double-sided dress tape and we would tape her eyes open and give her eye drops. So we would literally use the double-sided dress tape. You ladies know what I'm talking about, like hold your dresses in place. And we would use the double-sided tape and we would tape her eyelids to the top of her eyes. So she would sometimes go out to dinner and she'd be walking around like this and everybody would look at her, but she could see, and she could blink still, but we would give her the eye drops. And she's like, this is the best thing ever. And nobody ever told us that. We were just like, let's just try this, so that she could see and not have that like blurred vision and like the eye drooping. So we would use like double-sided tape when she would want to play cards, we'd go out to dinner or something like that to help her. So make sure that you give them a little bit of food with the medicine because it can cause GI upset. But the best time for them to eat actually is like 45 minutes to an hour after they take the medication, because now we're giving the cholinergic, we're promoting that muscle synapses to work better, and then there's less chance of them aspirating. Sometimes these patients can wear a sling to kind of hold their jaw open. They'll sometimes drool. My grandma would sit there at the table like this. And, she had a really good spirit about her. So we'd laugh. We'd be like, Grandma, you're drooling again. She'd be like, I know, I'm just waiting for someone to feed me. I love food. But, her mouth would be like, she would have that fatigue and her mouth would be held open. So the couple things you have to worry about with myasthenia gravis is myasthenia crisis. So your symptoms worsen, right? So now we're in a crisis. Maybe they had a recent infection or something triggered their immune system, and now we're in this crisis, okay? And your symptoms worsen. So now we're thinking respiratory, and we should always be thinking respiratory as the main end result for myasthenia gravis. If they go into acute exacerbation and it starts to attack the larger muscles, they're not going to be able to breathe. This is why patients end up in the ICU with myasthenia gravis, because they need ventilator support. They can end up in cholinergic crisis, which means they take too much drug, right? So what's the drug do? Well, if I take the cholinergic medication, it helps their eyes stay open. It helps them eat better. So what do? They start taking more cholinergic medication because they're like, oh, this helps me. And my symptoms are getting worse. So if I take more medicine, so they put themselves in a cholinergic crisis, or they have both. So now they have myasthenia crisis where their symptoms worsen, and they start taking cholinergic medication and they overdose on their cholinergic medication to try to control their symptoms. And now they're in a crisis. It's a mixed crisis. So their symptoms worsen because they have too much drug and they're in a myasthenia crisis. If they're in a cholinergic crisis, they've taken too much drug, our treatment is atropine. We would never do the tensilin test if they're in a crisis. And then I say other stuff. Okay, well, other stuff, just like with Guillain-Barré, is protective reflexes. So do we need to do eye drops? Do they need to wear a patch? Do we need to worry about giving, like when my grandma was having trouble eating, I didn't feed her steak, right? So we would give softer foods like French toast with syrup or something that's easy to swallow. So you want softer foods. You want to make sure if one side's weaker than the other, that you feed them on the strong side, give them time to eat, time their meals around their medications, making sure that we keep them safe. Like think of all the safety things. If they have double vision, do they need to walk with a walker? Do they need to have somebody help them get in and out of bed, because you don't want them to trip and fall because of their blurred vision, right? So all the other things that we have to think about with myasthenia gravis that protects the patient, not necessarily specific to that, but the impairments that go along with myasthenia gravis. Okay, any questions about that? Okay, so peripheral neuropathy. Okay, let's talk about peripheral. Now, you guys know this pretty well. Like, don't go crazy on peripheral neuropathy because you've studied it with diabetes, right? It's very similar to diabetic neuropathy. They have numbness and tingling in their extremities. They have no feeling, and we have to worry about injury. So we have to worry about burns, cuts, nails in their feet, hot water. They could burn themselves. How do we treat peripheral neuropathy? We could give B vitamins. Remember, no heating pads. They could burn themselves. Make sure they wear good shoes, just like you do with your diabetics. They should never walk barefoot. We should check their feet daily. They need to stop smoking because that actually damages the blood flow and the nerves to those areas. Check that they need a thermometer. That's what this says here, a thermometer to check the water temperature. They can't use their fingers to check the water temperature if they have peripheral neuropathy, right? So we need to make sure that they're safe. So water temperature is a big deal. Their feet are a big deal. We had a patient one time, I'll never forget this, come into St. Joe's, and the patient was septic. And they were so busy in the emergency room, they rapidly admitted the patient to the ICU, and we're trying to find the cause of sepsis. So as the patient comes through, they have a gown on, but they still have their pants on and their shoes and socks. So we're getting the patient in the bed, the patient's hypotensive, we're giving fluid, we're giving vasopressors, we're starting to culture everything, we're giving broad spectrum antibiotics. And we're like, where's this infection coming from? So we're getting urine specimens, we take the feet off, the shoes off, and guess what? There's a nail with pus draining out of the foot. I'm like, sepsis source found, right? The guy had no idea. He'd been walking around with it in his foot for who knows how long. He had no idea that there was a nail in the bottom of his foot, was putting his shoes and socks on every day, had peripheral neuropathy, he was a really bad diabetic. So it's really important to teach them. No smoking, check their feet, make sure they check the water temperature with a thermometer. The B vitamins help a little bit. No heating pads. You know, if you have an impaired judgment or you have impaired sensation, the heating pad can actually burn the skin. Okay, that's peripheral neuropathy. Restless leg syndrome. This is a feeling where they feel like they have to move, okay, especially at night. These are the night walkers. They get up and walk around because they feel better when they move. How do we help these patients? And a lot of times I had restless leg syndrome when I was pregnant, and I used to have to lay towards the end of the bed, and I used to have to just bounce my foot off of the edge of the bed to get to go to sleep. So a lot of times that you'll see them, they'll move their legs a lot at night because they have this feeling that they need to move. So what's really important? Well, it's really important for them to have a ritual at bedtime. So they get into a ritual at bedtime. They don't want to have caffeine before bed. They have to limit their activity at night. So it's not good for them to go exercise and have a cup of coffee and then plan to go to bed an hour later, because now that stimulus is happening in the extremities. You can use Requip. Okay, Requip is a medication that works well. Mirapex and Tegretol. Okay, so those are the 3 drugs that we use. They're not curative, but they help with a lot of the symptoms. If we talk, go ahead.
I think Deb had gabapentin on for that too. Do we need to?
Yeah, gabapentin. So gabapentin is like a great neuro drug. So we use it for chronic pain. We use gabapentin for chronic pain or nerve pain. Gabapentin's an anti-seizure drug. Sometimes it's used for migraines. It's used for restless leg syndrome. So we use gabapentin. I think of it as a very versatile nerve drug. And then if we move into trigeminal neuralgia, this is where the patients have the terrible, terrible headaches with a very fast onset. And this is usually elderly patients that get these headaches, terrible pain. It's the 5th cranial nerve, women more than men. And we think trigeminal neuralgia because that 5th cranial nerve goes across the face, down the cheek, and down the jaw. So clients typically avoid eating. So clients avoid eating, shaving, talking, mouth care, washing their face, and heat and cold. So a lot of times these patients will end up with dental caries or abscesses in their mouth because they talk like this, because they don't want to move, because they know as soon as they move, there's a chance that it's going to trigger that nerve and they're going to end up with a trigeminal headache, right? So we have to really educate the patients on making sure they provide good care and try to avoid triggers, but they still have to have good mouth care and dental hygiene. What do we treat them with? Anti-seizure meds. We can do surgery. If you remember where we did the balloon where they can actually balloon and compress the nerve. So they can actually do a surgery where they remove the blood vessel off of the nerve, or they inject the nerve, which actually a lot of patients help. I had a student last year that graduated last May, and her mom had it, or her grandmother had it. And she said that she ended up having the surgery and it literally almost alleviated. But the pain is so severe, and the lifestyle modifications that these patients take to avoid that pain, sometimes they're driven to suicide. It is such a terrible, terrible pain. So we try to do what we can to work with them to avoid those triggers. And then we have Bell's palsy. And this is facial paralysis. So the first time we see somebody with Bell's palsy, a lot of times we think stroke, right? Because we have facial drooping and paralysis on one side. Usually less than 45 years old. Most of these patients fully recover. And if not, after like 4 to 6 weeks of treatment, Whatever nerve damage is left is usually permanent, but a lot of patients can fully recover. It's usually acute onset and it's related to inflammation. They look like a stroke. And then how do we treat them? Well, we can give steroids. A lot of these patients have terrible headaches, so we can treat them with pain medication or steroids. Really important though, that they use a facial sling and exercises. Highlight this. You need to know this. It's so important to their recovery. If they don't do these exercises, they're more likely to have nerve damage. So you remember the facial sling that they have, right? That helps, like it's almost like a compressive thing to their face. And then they can use an eye patch, right? We talked about the eye patch because we worry about corneal abrasion. So just like with myasthenia gravis, if they have facial dripping and they're unable to blink, we want to protect that eye. And then they need to do their exercises for 3 to 5 times a day, 5 minutes in a mirror. So it's really important that they do it 3 to 5 times a day in 5 minutes each time. And those are the exercises. If you think, I think there was a chart that we had in the PowerPoint at one point. I'm not sure if Mrs. Phillips still has it in there, but that's like where they practice blowing out their cheeks. And maybe like we practice like blowing through a straw, or like squinting their eyebrows and like lifting their eyebrows and squinting their eyes and doing facial exercises and movements. And they need to do it into the mirror because they might feel like they're doing the exercise, but they don't know how well they're doing the exercise. So that's why doing it in the mirror is really important. These patients struggle. I think of this like, think of this as an example, write this down. If you've ever had dental surgery or Novocaine, okay, write that down next to Bell's palsy, because that's how we have to think about these patients. So if you've ever had dental, like let's say you had a cavity filled and they numbed one side of your face, are you able to drink through a straw? No. Are you higher risk for aspiration? Yes. Are you higher risk for like biting or chewing on that side? Like they always say after, don't have extremely hot or cold beverages. Try not to chew on that one side because you can actually cause damage to the soft tissue in your mouth. Well, it's the same thing with Bell's palsy. Like you're not going to have them drink out of a straw. You want to make sure that they eat on their strong side so they're able to chew well. You don't want to give them hard food to chew and swallow. You want to make sure it's soft food that they can swallow easily, and avoid really hot or cold beverages because it's almost like they have a paralytic on this side. So they can't feel or sense anything. So you don't want to give anything that would cause damage because of the Bell's palsy. Okay. So they can't drink through the straw when they're eating or drinking. They should eat soft foods. They should put them on the opposite side to make sure that we prevent aspiration and don't cause further damage. All right, questions? I'm going to go ahead and stop.